Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Oscalsis.
The oscalsis procedure will be the focus of this lesson today. We have Drea on the table as our patient. She's already prepared her leg that we would have in the hospital, that is no socks, no nylons, no jewelry. Our supplies, we'll take a look at the table now. We need an 8x10 extremity cassette, lead strip to divide the cassette into two sections because we'll be taking a plantar dorsal projection in the lateral. We need lead markers. We will be using a tape measure, and we actually have a lead shield on our patient as we speak. The equipment setup, I'm going to start off with the plantar dorsal projection. The tube is at a 40-degree cephalic tube angle, and because of the 40-degree cephalic tube angle, you might recall that rule of thumb for every 5 degrees of tube angle, you want to adjust the SID on the gauge by 1 inch. So instead of the gauge saying 43 to the tabletop in this particular room setup, the gauge says 35. Now, we are going to measure the SID once we get set up, but I am using that rule of thumb to do a preliminary setup of the X-ray equipment, and the gauge does say 35. Okay, we're going to focus on our patient's leg now. I have an 8x10 extremity cassette. I want the ID blocker to the medial aspect of the affected leg, and this will be the side that we're going to put the plantar dorsal projection on. You have your patient extend their leg so the leg is straight with the body. You don't want the leg coming off at an angle or the body twisted. That'll actually close the subtalar joint that you're trying to demonstrate. So make sure the leg is coming off straight with the patient's body. And my tube won't go back any further, so I'm going to have my patient slide herself back just a little bit. I think that'll work now. Okay. This side of the cassette, we're going to put the lateral position on. So I'm dividing the cassette in half. The part film reference point is the plantar surface of the foot should be level with or up to 1 inch above the bottom edge of the foot. We have different sized feet, from maybe a size 5 shoe up to maybe a size 13 shoe. So there's got to be a little bit of play where you put the actual plantar surface. Again, it should be level with the edge or up to about 1 inch above the edge of the film. We're going to want the foot flexed back to 90 degrees. Now, most patients who've had an oscalsis injury, this may be difficult to do. So you might give them an arm restraint or a piece of tape, something in a rope type shape, and put that tape here and let the patient pull the tape back to support the foot here. We're going to let her relax just a little bit because we don't want her flexed any longer than she has to be. Okay, that's my preliminary setup with the foot and the cassette. I'm going to come to my tube now. And I'm going to get the crosshair coming right down the center of that foot. I'm going to collimate closer to the size that I want. Okay. Now, I will need to have my patient flex her foot back. And if the camera can focus on here for a second, with the toe straight up in the air, I want you to take a look at this level here. We want the tube entering at the level of the bases of the metatarsals. That'll actually be like the lower part of the arch, or the most posterior part of the arch. You've got your metatarsals, and you want that crosshair entering at the level of the base of the metatarsals with a 40-degree cephalic tube angle. The purpose of that is to open up the subtalar joint. So I'm going to look at the crosshair now. When we turn the light on, you won't be able to see from the camera, but the edge of the foot sticks out this way on the lateral aspect where the medial aspect of the foot, because of the arch, is further away. So the crosshair is going to look like at an angle, and that may tend to confuse you. I'm going to have you focus right in the center of the foot, and we'll see if we can demonstrate this on tape when we get this set up. Okay. Okay, from the perspective of the camera, the crosshair is entering here or here, and see how the two lights are going there. It just looks like it's crooked, but please know that it's not. It's just the shape of the foot causing the light to have a divergent type shape. So I'm going to focus right here, right in the middle of the foot. That's where it's going to tell me where it's entering. And I think the camera can see that right now. The entrance point I'm happy with because it is at the base of the third metatarsals. Again, I'm looking at the center of the foot, not the two lateral edges, because the light is reflected at an angle. The camera has realigned itself a little bit so you can see better what I'm talking about, how this crosshair looks like it's at an angle. Again, my point being, I don't look at this edge, I don't look at the medial edge, I look right in the center. That is the level that should be entering through the base of the metatarsal region. CR is coming through here at a 40-degree cephalic tube angle, and it's exiting to the center of the cassette. I can actually see the crosshair on this side. It'll be difficult for you to see from the camera, but this crosshair is actually coming right to the center of the cassette. That's with the foot flexed, okay? And our patient actually went into a recumbent position. She was originally in a seated position, which many of your patients might start out to be. They're very curious. They like to see what's going on. But as time goes on, they get uncomfortable, and it is more relaxing for a patient to go into a recumbent position, especially if they're a little shocky from pain or uncomfortable. So again, communicate with your patient, find out which way they would be more comfortable. Recumbent or sitting is okay as long as the leg is straight and the foot ends up being flexed to 90 degrees before you make your exposure. Okay, so we're going to look here, and we're going to have our foot straight up in the air. I'm double checking my entrance, my exit point, and collimation. I have a little bit of light over the baby light over the lead strip. I'm showing collimation on this aspect, and I'm putting the marker to a corner in this relationship. I think you can see that. And it's just going to go up to the corner inside the collimated field. Now I want to demonstrate something else. Drea's foot is not very wide over the metatarsal heads. But if she had a web-shaped type foot and her metatarsals were wider, you would actually have, well, we can show you some here. I don't know if the camera can see it, but there is some shadowing of the body part over this blue strip. I'm moving her foot so you can maybe see what I'm talking about. See how that shadows over the blue strip? Okay. Well, with the foot straight up in the air, if you have shadow over the blue strip, it is more than likely the metatarsal heads, and that is not a part of the os calcis exam. So you can run your finger along the foot and identify what has actually gone over that lead strip, and as long as it's the metatarsal heads, soft tissue shadow over the blue strip or off the edge of the film is okay. It's your os calcis region that cannot have the overlap over the lead strip. Okay, I've done my preliminary setup. Just to review, I have a 40-degree cephalic tube angle. I am entering at the base of the metatarsals and exiting to the center of the film. I've collimated to the field circumference with a little bit of light over the lead strip. The foot is straight up in the air, and I have double-checked shadowing over the lead strip to verify that it was only the metatarsal heads. Before I actually shoot this X-ray, I'm going to do a quick job of tape measuring. I'm going to rearrange my position now so you can better see what I'm talking about. Okay, I'm taking the tape to the center of the film where it's exiting. And then I'm going to look at my tape measure, 1/3 of the way into the tube housing. And my actual SID is 45 inches. Okay? It's 45 inches. That is beyond acceptable limits. You shoot for the 40 inches SID. If you're 39 to 41, be satisfied with that, but anything longer than 41 or shorter than 38, you should do some adjusting with the tube. So we're going to talk about a little bit of principle here now. A quick way to do this, follow me mentally right now. I mentioned we were 40, I think I said 45 inches of SID. Our target is 40. If you subtract 40 from 45, that's 5 inches. Okay? So subtract what you're off of. Find out how much of a difference you have. Okay, we're off 5 inches. In this case, we happen to be on the long side or further away from the cassette. Take your 5 and divide that in half. So now, okay, she told me to divide it in half. I have 2.5 inches. What I'm going to do with that is I'm going to come down using the gauge on the collimator housing. I'm going to come down that 2.5 inches, and then I'm going to go in towards the os calcis, the other 2.5 inches, and that will compensate for that 5 inches that we're off. Okay? Follow the thought process now. What if it was 37 inches? What if you actually got 37? Well, 37 from 40 would be 3. What is half of 3? Well, 1.5. And you're short. Well, if you're short, you would go away from the patient 1.5 inches and up 1.5 inches. Okay? So, for the scenario that we have here, we were off 5 inches. We're going to come to the gauge now. And it actually says a little over 36. So I'm going to use my gauge because it's already set up there. And a little over 36. So a little over 34 would be 2. And then I'm going to come down 1/2 inch. That's adjusted for 2.5 inches. Now I'm going to come back to the cassette. See how it's not centered to the cassette anymore? And I'm going to come in my 2.5 inches. I'm going to come right back to the center of the cassette, right here. Go back to my starting point. I came down 2.5 inches, and then I moved it back to the center of the film. That should get me my 40 inches. And I wouldn't check myself in the field because speed is important when somebody's in pain, but I'm just going to show you here real quick. And I now have my 41 inches, which is close enough. It's within that 1 inch area there. Okay. So, leg is straight. Plantar surface of the foot is flexed to 90 degrees, entering at the bases of the metatarsals, exiting to the center of the film with a 40-degree cephalic tube angle. That should get us an adequate plantar dorsal projection of the os calcis. Okay. We're going to pretend for a minute you're a patient and you were having fun on a river and you wanted to jump off of a waterfall into a deep pool. Well, you miscalculated and you landed on a rock. That is a possible os calcis type of injury. You fell, you jumped off of a waterfall. How much pain is your foot going to be in? What's the likelihood of you being able to flex that foot to 90 degrees? It might be impossible for you to flex it. So we're going to look at her foot here for a second and pretend she wasn't able to flex that foot. Okay? It's just in a relaxed position. She's in too much pain. I asked if she could flex it, and she gave me this no way sign, and so I'm not going to force the issue. But we still need to be able to get through that subtalar joint. So instead of making her flex the foot, I'm going to get a positioning sponge. And what we would do is we would elevate the foot. And see, as I'm elevating the foot, what's happening to the relationship? The foot is at a relaxed flex, but as I elevate her foot, not handling the os calcis, See what's happening to the joint space region? It is becoming at a 90 degrees. So that's a positioning alternative to help you get through that joint space. Okay. X-ray techs are known to be creative. You know your reference lines, you know your anatomy that you need to demonstrate, and you use positioning tools to help you get to that. Okay, we've done our plantar dorsal projection. If you've done a good job of positioning this, when you look at your radiograph, you will see the first and the fifth metatarsals. If they're seen, they'll be seen equally on the two sides. Okay, we're going to take a look at the foot from the very plantar surface perspective. I was mentioning a minute ago, if you've done a good job, you will see the metatarsals equally spaced. And what I mean by that, picture the foot straight up in the air, and the os callis is immediately under the metatarsals here. And Andrea's foot, again, she kind of flares out just a little bit, and the distance here and the distance here should be comparable, so the width will be the same on a radiograph. What happens if her leg was not straight or it was rotated medial? I want you just to kind of take a look. I'm over-exaggerating this now. What's going to happen here is the fifth metatarsal, you're the X-ray vision now. Pretend you're the photon path. You're going to X-ray this foot and this side of the foot. The fifth metatarsal side is going to be projected right over the os calcis. The first is going to be projected up this way, and you're going to really see that first sticking out to the side. That's what we talk about. The width would not be comparable. If you see the first metatarsal more than the fifth, you will know that the foot was rotated too medially. On the same token, if you had the foot rotated laterally, the fifth would be projected down on the radiograph. It would show up wider. The first would be projected over the os calcis. So if you see the fifth metatarsal, you know that the foot was rotated too laterally. And I'll just remind you, anatomically, the fifth metatarsal is more posterior than the first. That's how you'll know the difference between the two metatarsals. The fifth actually hangs back more posterior. It's in a lower relationship. So make sure you review your foot anatomy, and it will be easier for you to identify whether the fifth or the first is showing up. And we'll review this when we do films. Okay? We've just made our exposure on our plantar dorsal projection, so I'm ready to come back to my patient. And I have her pick her foot up, and I move the lead strip, and I ask her to turn on to the side that's hurt. And I'm going to look at her and see how she's more comfortable. Are you comfortable like that? Would you like to bring the leg over? Yeah. Is that more comfortable for you? Okay, get your patient more comfortable. Realign your lead protection. Okay, good. And again, we want to flex the foot. And now your your lateral PFR information is you take your tibial malleoli, the medial malleoli, and you want to be 1 inch below the malleoli to the center of the film. So I'm getting that tentatively set up. I have now a 90-degree tube angle perpendicular. I no longer have that cephalic tube angle. And I'm going to center the central ray 1 inch below that malleoli, exiting to the center of the film. Okay. This one can have tighter collimation than the plantar dorsal. I've got baby light over the lead strip. Okay. And positioning the leg will be just like the ankle. You want the malleoli superimposed, exactly one on top of the other. And I can tell that her foot is flat on the film, so the likelihood of me needing to roll her hip back. Can you bring your hip back? Is that better now with your foot? Okay. Bring that foot back to get the foot, about 15 degrees off of the plane of the film will more than likely get me a true lateral. So we're going to now palpate the two sides of the malleoli to find out if that indeed is the case. Okay, and I'm happy with that positioning. And then I go to get my 1 inch below the malleoli to the center of the film and collimate. Okay. I've got tight collimation, but I am clearing the oscalcis. Okay. The malleoli are superimposed one on top of the other. Foot is usually about 15 degrees off the plane of the film with the foot flexed. Again, 1 inch below the malleoli to the center of the film with the malleoli superimposed one on top of the other. Drea has a relatively small foot. I'm verifying that I'm getting part of the navicular on the edge of the film here, inclusive. If she had a longer foot and I was concerned about including the navicular here, I could